Joe King. I'm the owner of Physical Therapy Advantage. I'm originally from Nebraska, so I'm not an Illinoisan at all. But I've been out here for almost 22 years. I graduated in 1997 from physical therapy school, and I moved out to the Chicagoland area, and I've been out here ever since. I opened up the clinic about 12 years ago, and I've been in this location now here for 12 years. I've enjoyed some nice success. I can't believe it's been 12 years already. But it's been really, really nice to be able to be in the community and work within the community. And that's why we started doing these workshops about 3 years ago, is to get ingrained into the community even more and offer information, education to the community about different ailments so they can make the best health care decisions for themselves. Over the course of the 22 years that I've been out, I've seen thousands of shoulder injuries, and my staff as well too combined. We have a combined probably 50 plus years of experience between myself and my two staff people. So we've been out for a while, seen a lot of shoulder injuries. And a lot of the success that we've had has come from doing manual therapy, postural retraining, and a lot of education and retraining of bad habits more than anything. So what we're going to talk about today is finding out what are the major causes of shoulder pain, because there can be a lot of things that go on with shoulders and can basically make it complex and miscommunicate, and you're not sure where the pain is truly coming from. So hopefully we'll be able to help give you a little better idea of what's going on in the shoulder, and realize that it may not be the shoulder that's bothering you, it may be the shoulder that's bothering you. But once again, so you can make the best healthcare decisions for yourself. All right, so the major question is, and this question went out to most of you if you registered online, is in the past 30 days, what was the worst shoulder pain that you've had? If you had to rate it 0 to 10, 0 being no pain, 10 being the worst pain possible, what would be the worst pain level that you could say that you've had in the last 30 days? Anybody want to offer? 8. Okay, can I ask what you were doing when you had that 8 out of 10 pain?
The day after, I was watching some physical therapists on YouTube suggest exercises to do for my shoulder pain.
Okay, and so you did those exercises and you had an 8 out of 10? Okay, all right. Sorry about that. Anybody else?
Yeah. A 9.
9, wow, okay.
I'd fallen down some stairs,
Okay.
and that night I was laying in bed and tried to pull my sheet over me, and I couldn't do it. Even the lightness of the sheet, I could not reach my hand over and pull it over. And I had to scream. I mean, it was just so painful.
Okay, wow. All right, thank you for sharing. Anybody else?
Also
9, okay.
I got thrown by the surf about a month ago.
Oh.
Picked up and slammed.
Not local, I take it. You weren't at Lake Michigan. Okay.
Yeah, it's been a long month since that point.
Okay.
The shoulder hurt before that, but not like this.
Okay. Great.
My pain has not been bad recently. I injured it, I think, almost a year ago, and slowly it's felt better. So my pain could be 3 or 4.
Okay. It's okay.
But I baby it so it doesn't come back.
You're avoiding using it.
I'm avoiding it.
Okay. That's not good either.
No.
That's obviously you're struggling to use your right shoulder. Are you right-handed?
Yes.
Okay. That's really not good then. All right. Anybody else? All right. Well, thank you for sharing. One of the things I want to kind of encourage you guys is to interact, and thank you for sharing those things. And we're going to do some more interaction here in a second. But anywhere along the lines that when we're going through, if I mention something, raise a hand, ask a question. I'll try to answer at that point in time. If it's something I need to answer later in the seminar and or afterwards, I'll let you know for time constraints. But definitely, I want this to be a two-way street here, not just me talking to you. I want feedback, interaction, participation on your part as well. So, all right, that being said, go ahead and put your clipboards down and stand on up for me. So we're just going to do some movement testing to kind of see how things are. Don't do anything that really truly aggravates you. If you know this is going to aggravate you, I'm not looking to cause aggravation by any means, but just kind of want to do some movement testing to see where things are at. So we're going to start actually with our neck. It's one of the things we do is we try to clear things above and below the painful area. So can you look up to the ceiling for me? And then look down to the floor. All right, and then look back up there. Either one of those bother you? Nope. All right, good. Now I want you to look over your right shoulder as far as you can, and then the left shoulder as far as you can. Any pain with any of that? Nope, good. All right, now we're going to tilt the head, so bring Try to bring your right ear down to your right shoulder, not your shoulder up to your ear. And then we're going to go the opposite way, left. Okay. Any trouble with either one of those two? No. All right, good. So hopefully we kind of cleared the neck out maybe a little bit, but not 100%, but we definitely want to make sure that the neck is not a part of this. All right, so we're going to do some arm movement here. So can we raise the arms out in front to our shoulder? If it hurts, don't do it. Not too bad. Okay, can we go up overhead? All right. Any pain with that? Obviously, I see one. I see two in the back. Okay. Come on back down. That's good. All right. All right. So now out to the side as if we're doing a jumping jack. And just kind of just gently. And if you have to turn the palms up, that's totally fine. Yeah. And stop before any pain or stop when you need to. Good. All right. Obviously, I see a pain one. This a grimace. Any other pain? I saw some shoulders that weren't going up quite so high. All right. Next one we're going to do is we'll take one arm at a time. So take your good arm, whichever that is, and reach behind your back and try to reach up as far as you can. All right, good. See how that feels, see how far you're up, bring that arm down. And then try the painful. Like I said, just go to where you feel you need to stop. All right, is that painful for anybody? Yeah, I see a lot of head nods. Okay, bring it on back down. Good. Now, one of the last things we're going to do is I just want you to bring your arm up and then just, can you hold it there? Okay, is that painful? All right, nothing's having to hold it up. You're having a hard time bringing that up. Okay, and I saw a head nod back there. Is that still okay? Go and bring them on down. Very, very good. Okay, you guys can go ahead and sit on down. Thank you. Thank you very much. All right. So the next portion of it is I would like to do a quick demonstration, kind of take what we just did there and kind of move it along just a little bit to collect a little more data to kind of show you what we do as therapists that is beneficial in collecting data to finding out where your shoulder pain is coming from, because technically it could be coming from hand, elbow, shoulder, maybe shoulder blade, maybe even into your neck and a few different portions of your neck. So we just want to make sure that we're getting to the right spot. And Miss Lee, you can come on up to the front row. You don't have to be shy. So with any volunteers that feel like they would want to find out a little bit more? Okay, come on up. I appreciate it. Okay. I'm Joe.
I'm Bobby.
Bobby? Nice to meet you, Bobby. All right, so I'm just going to have you do a few things. I'm going to have you stand right there for me, okay? And I'm going to come a little bit more level here. All right, so can you hold your arms just like that for me? And it's your left one that bothers you. Is that correct from what I could tell on the back? Okay. So I'm going to try to gently push you down. Don't let me do that, okay? Ready, hold. Good. Any pain with that?
Oh, a little bit.
Not too bad? Okay. Now I'm going to have you turn your palms down like that.
Actually, the pain's in my forearm on that way.
Oh, that way, okay. When you turn it down like that?
Even when you were pushing down on it.
Okay. And I'm going to try to push down now again. Ready, hold. Ah, that doesn't like it so well. Okay, great. And now what I'm going to do is I'm going to have you, can you come up on the table there?
Maybe.
All right, actually, I'm just going to have you sit. I'm going to sit on the edge of the bed there. There you go. That work for you?
Yeah.
All right. So now what I'm going to do is I'm going to check your arms real quick. So I'm just going to bring this arm up. Not too bad.
Perfect.
Perfect. I haven't heard that in a long time. That one's okay too? Great. All right, going to do the same thing on this side here. I'll do all the work, okay? Try to let me do it at least. Is that painful?
Yes.
Okay.
Yes.
Yes? Okay. All right. And now we're going to do a little arm wrestling, okay? All right. I'm going to try to pull your arm down and out like that. Don't let me do that, okay? Ready, hold. Good. Any troubles? Beautiful. And now we're going to do the same thing on this side. I'm going to try to pull you down and out. Don't let me do it. Ready, hold. A little tougher. Pain too, or just tougher?
Just tougher.
Just tougher. Okay, great. All right. That's what I wanted to kind of figure out a little bit. I got to do a couple other things real quick to see what we're dealing with. Do you mind lying on your back?
No.
All right. Go ahead and lay on your back here. And I'm going to give you a bolster really quick for your knees so you're a little comfortable. Good. So I'm going to do a little poking and prodding along your collarbone here, okay? Does that okay? All right. And now if I go into this area, does that hurt? Does that hurt? Great. All right. So I'm going to check your arm right here really quick. I'm just moving her arm out to the side a little bit and bringing her wrist down. You'll see it on the other side. No troubles there. I'm not expecting anything on the right side, but I have to use it as my barometer. No troubles there. And I'm going to bring your thumb into your palm here and go down. Any trouble there? Beautiful. All right. So now let's check the other side. Are you okay in that position? All right. Does that bother you? No? All right, good. Are you okay?
Yep.
Any trouble there? No. Okay, good. And make a fist
There's
there.
a little catch there.
Just a little?
Yeah.
Okay. Anything going down?
No.
Okay, good. And if I go out like that,
No problem.
great. And going down,
No problem.
no problem. And if I raise your arm overhead, does that bother it?
Yes.
That bothers it. Okay. All right. Thank you.
You're welcome. Thank you.
Yeah. Would you be willing to do the second part of the demonstration later in the seminar?
Absolutely.
Okay. Thank you. Come on up, Bobby. You want some help? Yes. I'll help you. There you go.
Thank you.
You're welcome. All right. So what I was doing there, I can find my sheet, was just trying to find out some further information to determine whether it was her neck that was her problem, maybe a little bit, maybe in the side of her neck and around her collarbone. Was it her shoulder itself? Or when I was actually moving her hand in some different positions and going out, I was actually checking the neural system a little bit. Sometimes the nerve can get irritated and replicate pain. And do we know where it's coming from? And sometimes, and actually a lot of times, if you've had shoulder pain for a long time, unfortunately, and it can happen not just with shoulder pain, with any ache that you've had for a long time, and pain, especially if you have some what we call radiating pain going from one area and traveling to another, it actually might become neurological, and it actually might be multiple things causing troubles. You may have 2 or 3 issues going on. So we like to try to get to the root cause of what may have bothered it at the beginning, and now 2 or 3 other things have happened since because you've been dealing with it for 6 months, a year, who knows how long. So it just helps us collect a lot more data to figure out what you can do, what you cannot do, what's painful, and how do you present, and what's positive, what we call a positive finding. And then we try to mesh that all together and figure out and sort things out and then devise a plan that's specific for you guys. So what is the rotator cuff? The rotator cuff is a group of 4 muscles, and there is a diagram, so I've put in your packet there's a picture of the front of the shoulder blade that has the rotator cuff, and there's a picture of the back. And it's going to look like this. You're going to see one side from the back view of your shoulder blade, and then you're going to see one side picture from the front side of the shoulder blade. It's got those muscles marked for you. But it's a composition of 4 muscles, okay? And really quickly, you're not going to remember them. That's why it's on the sheet. If you're looking from the front side of you, you've got your collarbone there, or your clavicle, we call it. And this big honking thing on the inside part of your shoulder blade is your subscapularis muscle. All right? And then if we flip it on the back side, we've got 3 other muscles. On the top part of your shoulder blade, we have the supraspinatus. On the bottom side, this triangle type muscle along the shoulder blade there that's going up is your infraspinatus. So supra being above, infra being below. And the guy on the bottom down here, this little guy on the side, is called your teres minor. His brother down here is teres major. He's a little thicker, and he's not part of the rotator cuff specifically. I don't know why they excluded him. He's bigger, bully. I'm not sure if they ousted him, but he's not part of the rotator cuff itself. But the 4 muscles are the teres minor, infraspinatus, supraspinatus, and subscapularis. And they work the rotation of your shoulder. That's what they're responsible for. And then the supraspinatus up here also helps with some shoulder elevation, or what we call abduction or scaption out to there. All right. As you can see, it surrounds and supports the shoulder. The shoulder, if you can tell, is what we call a ball and socket joint. The ball being your arm or your humerus going into a socket, that round part. But the funny thing is, it's not really a socket. If you can see, that's not really a very deep socket. If you think about your hip joint, the hip joint is a true socket joint. It's really, really deep. That's not really a very deep socket there for the shoulder. The reason being is it's the most mobile joint in the body, okay? Because we have to do, and I have limited joint mobility. My wife teases me all because of it, but we have to do all these sorts of things with that shoulder. It is the most mobile joint in the body. That is why it's not a very deep socket joint. If you could do that with your hip, only contortionists can do that with their hip, and they've been to circus school to do that. But if you tried to do all those same kind of movements with your hip, you wouldn't be able to do that because it's a much deeper socket joint. But because of the ball and socket being shallow here, we are able to do that. So it relies heavily on the muscles to support that. So it relies heavily on the rotator cuff to support that joint. There are small ligaments that support this. And I'm going to kind of show you here. They're very thin. I mean, we're talking millimeters thin. There is a down along here. There's one in the front. There's one on the top. And there's one in the back. So there's a front, back, top, and bottom ligament. But they are very, very thin, like rubber band. We're talking rubber band, small rubber band thickness. And they're not totally elastic, but a little bit elastic. So they're supposed to control that joint a little bit. But they get stretched out and torn quite easily. So once again, it relies really exclusively on the muscles to support that shoulder joint. Now there are other muscles surrounding that too, and we could talk about those, but mainly the rotator cuff is the one that we have to worry about more. So multiple areas that have to work together for shoulder movement. As I mentioned to you before, we have the collarbone, okay, or we call it, the technical term is the clavicle, that goes from your breastbone, your sternum, out to the shoulder region. And when we elevate like this, it's a bucket handle. For this last little bit of shoulder elevation or overhead reaching to go like that, this has to flip up like a bucket handle. If it's not, if this isn't moving where it's supposed to here, or if it's not rotating up at your sternum here, your breastbone, if it's locked, you may not be able to get all the way up, and it may be painful out in your shoulder. So we have to look at that. We have the rotator cuff itself, which is a part of it. So we have those four muscles that are needed for the shoulder motion to occur. We actually have the shoulder blade. So if you can envision, arm movement has to occur. It doesn't just occur that this goes like this. If you watch my shoulder blade, if you can kind of see it in my shirt, that shoulder blade has to rotate as I do this. Or even as I do this a little bit, it has to rotate just a little bit. So there's some movement on your ribs that has to occur when we move and raise things overhead, which is very important. And another name for the shoulder blade is what we call the scapula. And like I said, it coordinates that overhead movement. And then lastly, we have the shoulder joint itself, the ball and socket. So as we raise things up, if you can kind of see here, as I raise that up, this ball has to spin in that joint, and it also has to drop down. If you see the ledges out here, if we just did this, that is that ledge jamming into that shelf there, okay? Some people are a little hypermobile. They could probably go all the way up with their palm down, but if you truly technically, that's where it stops. That's why we have to rotate our palm up so the round surface goes, and now I can clear that shelf. But not only do I have to rotate, I have to drop. The ball has to drop down. So we have to coordinate those movements in there as well. So if it's not moving correctly, rotating, spinning, dropping, and whatever, depending on the movement, we have to assess that as well. So those things can then pinch up. You have, as you can see here, that rotator cuff, those muscles, are coming up underneath part of this, of your shoulder blade there, and this area, dome area, this shelf, and then it attaches to your arm. And that's kind of what this is showing here. I took away the shelf a little bit, but you're seeing all the different rotator cuff muscles coming across in the front, over the top, and from the back side, all attaching to the outside part of your shoulder, right there, okay? And they help, like I said, rotate it, either rotate it in or rotate it out. And then you have the big biceps muscle in the front, and that's what this represents here. You don't see the big biceps down here, but you see that tendon sitting right down there. And what will happen there, also when you start to do stuff, is that tendon can also get wedged. So not only if this ball and socket is not moving like it's supposed to, it can jam the rotator cuff up into this shelf in the bone, or it could jam the biceps tendon. And that's where you get, if you've ever heard somebody says impingement syndrome, okay, or the rotator cuff tendonitis, or biceps tendonitis, which are all shoulder pain causers or pathology. It's because they're getting irritated and getting jammed up in there. One of the reasons why. So we have to just look at those things and make sure, okay, where is it coming from? What's happening with everybody? All right, so that's a lot of information, but that's the meat and potatoes of why you guys came, to find out what that rotator cuff, and there's a lot of things moving on. What questions do you have about that, so we can kind of clear those up before we move on to a little bit more? Yes, Bobby?
Well, on my YouTube research,
When somebody said that all the muscles that hold your shoulder in place, if one of those is weakened or torn or something like that, your shoulder is gonna not fall down, but it's gonna fall up because the deltoid muscle is so strong. Is that true?
Possible, yes. So you could have it where, if, depending if it's one of the rotator cuff muscles, bicep muscle, whatever, if you have something that's torn or weak, there's a possibility that, you know, the shoulder may drop. It could drop because it's not being supported like it's supposed to, or it could just do the opposite. It can actually go up. And it could be because of the deltoid muscles that and then are on top of here. So you have your anterior deltoid in the front, and that helps do this. You have your middle deltoid, which is off the side, and that helps with the raising here. And you have on the back side your posterior deltoid, which helps move things in the back. So those can go into spasm and play big brother. Whenever you have an area of injury in the body, it doesn't matter, in the shoulder, wherever, bone, bruise, a ligament, a muscle strain, it doesn't matter. You've hurt something, muscles surrounding that area of injury will go into spasm to protection mode. And that can cause you to compensate and posturally be out of whack. So yes, so the deltoids can cause that and kind of cause it to shrug up. It can also be coming from your neck muscles, your upper trapezius and your levator scapula. Those two neck muscles, very closely related. They're hooked into the shoulder blade. And you know, you'll see a lot of people like this, or you'll see people that are hurting with their shoulder. How do they raise their arm? They're like this, and then all of a sudden, yeah, I'm raising my arm. Yeah, they're not raising their arm, they're shrugging their shoulder, because this is in a spasm now. Or the biceps may go into spasm. It's not unusual for the biceps to go into spasm. So especially when you're trying to elevate your arm, and now this bicep should not fire when you're doing that, but it's firing and causing things to misfire here. Or now you're having other pain, like, oh, my bicep is killing me, and stuff like that. But it's coming from your shoulder because it's overfiring now. So there's lots of different things that can occur. So I'm not saying that YouTube is wrong in that, but that's only one part of it. Yeah. Any other questions? That's a great question, by the way. Yeah.
when they say you're going to do surgery and they're going to do the rotacuff, what do they do?
Well, it all depends on what's done, what's wrong. So, like I said, the rotator cuff is 4 muscles. So it all depends on if there's a tear, and typically they don't, and I'm not going to say this for all surgeons, but typically if it's a 50% or less than a 50% tear, most surgeons aren't going to do surgery. They're going to wait till it's over 50% of a tear, and they will do an MRI to determine that. And they'll determine based on what you can and can't do and what your needs are and everything else. But it all depends on where the tear is at and what is torn and how much work has to be done. But typically, the tear occurs in these tendons because they're getting jammed up underneath the shelf. And what will happen is it basically rubs and frictions, or sometimes it's a fall, and it jams up in there, and that will jam it and it'll cause the tear. Or if you are weakened for many, many years per se, and you overstrain it, I'm going to grab something really, really heavy out in front of me like this, and all of a sudden that muscle just goes, or I should say goes, tears, pulls apart, then you have a tear. And they'll go in and basically try to bring the two ends together and sew it up if they can. So it depends on exactly what's going on, but if they do a rotator cuff repair, they're typically bringing the two ends of the rotator cuff that were torn, and they're trying to sew them back together. Sometimes it's actually in the muscle belly, more where the muscle and the tendon. The tendon is the white part, the muscle belly is the red. So it may be more in where the tendon and muscle are junction there, or actually a lot of times it's more in the tendon itself that will cause that tear. Does that answer your question, Ellie? You're welcome. Any other questions?
So does that pain come on gradually if you tear it? Can it?
It depends. I mean, if you completely tear it, you actually won't have any pain from the tear because the nerve endings are gone at that point in time. So if you have a complete tear, you won't feel that pain. You'll feel the pain from the muscles spasming around it, and you'll feel the pain because of the abnormal mechanics that are going on and the pinching from something else. And that's why you may have pain up in here, pinching that's going in the joint, but you have pain shooting down the arm because it's what we call a referred pain, because other muscles are firing abnormally and causing that to hurt.
So you won't necessarily have pain here?
Not necessarily.
Not at all?
Maybe not. And that's why we do all these different tests, exactly. Yeah.
What's the success rate of shoulder surgery?
I'm not a surgeon, I can't tell you what their success rate is.
I heard it wasn't very good.
The shoulder surgery is a very difficult surgery for the fact that we mentioned before. It's the most mobile joint in the body. It has to do so much. I will say they've gotten much, much better. The last dozen rotator cuff repairs that I've seen or the clinic has seen probably in the last 2 years have done very, very well. Before that, 50-50, 60-40 success, maybe 70-30. I mean, it kind of varies. It also depends on the client. I mean, I have a lot of clients, unfortunately, I should say a number of clients over the course of 22 years who weren't very compliant with what the doctor told them to do. They weren't so successful. So a lot of the onus is the surgeon good in doing what he's supposed to be doing, but also is the client good in doing what they're supposed to be doing. It's a two-way street.
One more question.
Yeah.
So instead of surgery, can you always fix this without surgery?
You can't fix a broken muscle. So if it's torn, it can't.
It can't heal itself.
If there's been research showing that, say it's a small mild tear strain, that it can scar tissue up a little bit. So yes, it can do that. Is it the same as it was before? No, because you can't really undo that. But can you strengthen this musculature around it enough that it's scarred down enough and build some scar tissue up? And hey, I'm pretty mobile and everything else is moving really, really well. I may be a little bit weaker in that area, but overall not too bad. And I know that I can't do these motions very well. I have to limit that. You can be pretty successful. So therapy can be, I've had a number of clients who have not had their biceps repaired, have not had their rotator cuff repaired. But yeah, they say, okay, no more tennis, or overhand serves are now here instead of here. Or my volleyball career, okay, I'm going to here versus doing an overhand serve, or I'm not an outside hitter anymore. Those sorts of things. They make those choices sometimes, or they know that if they're going to do it, it may hurt. So I've had a lot of people who've chosen not to do surgery and been successful and been good, but they may have to modify their activities a little bit too. So there's a compromise.
I had a girlfriend, I think is it called a reversed shoulder replacement?
Reverse total shoulder replacement, yes.
That's a popular thing now. It's different, isn't it? They do something different.
Typically that they use a reverse total shoulder replacement once a rotator cuff surgery has failed. So if rotator cuff has been torn, they try the surgery, that surgery has failed unfortunately, and then they go on and they're still having trouble. A lot of surgeons are going to what they call a reverse total shoulder surgery. I can never say that very fast. And they basically reverse it. The ball, they cut off the socket here, they cut off the ball and they put new prosthesis, and they put the ball, a prosthesis ball, against your shoulder blade, and then the socket, a new prosthetic socket on your arm. So it's a reverse. It's kind of, it's ingenious actually. And they're having some great success. I have a gal who had it done 2.5 years ago, maybe it was, and you wouldn't even know it. Her arm, she has nearly full motion, which they typically say you're not going to have. She's back working out at the gym. She's doing stuff, and she is 70. She had it done like when she was 67. Fantastic. So, I mean, I've seen some outstanding, and I've had some other clients too, younger, older, who have had it done recently in the last 2-3 years and seen some great results with it. So, yeah. All right. So, we're going to move on here to number 3. So, as that states there, if your pain in the shoulder, what we say is reproducible, then most likely that's a good thing for us, because then we think we can reduce it. So if we're able to reproduce your pain, which people don't like to hear that, then we like to know, then we kind of figure out what's going on. We should be able to reduce it. Gives us a better chance. If we can't reproduce it, it's like taking your car to the mechanic and, hey, it's doing this, it's doing this. Mechanic can't, it's not doing that for me. He can't really fix it, right? If you can reproduce the pain, reproduce those symptoms, we typically feel as a therapist that we can reduce it. So we have some things people talked about earlier as far as hurt their shoulder. So we have surfing, which is not normally around here, but surfing hurt. You said somebody fell down the stairs, which is another thing we don't typically do for our shoulders, but definitely can hurt it. But what are some activities that are now bothering you? I know somebody emailed back that sleeping is bothering them. Is that true for a lot of people? Okay. And I think another one was, I had somebody say driving was bothering them. Is that okay? Anything else? What other activities are on your, what's that? Exercise. Exercise. So lifting. So that could be weights, groceries, grandchildren, kids, okay? So we have weights, kids, grandkids. Those are called G-kids here. All right. Yep, groceries, packages, exactly. What other things? Somebody said lifting sheets, so kind of with sleeping. Pulling sheets up. Getting dressed. Yes. Coat. Hair. Yes. Showering. All right. Perfect. Thank you. And the point of that exercise is to realize that many, many things can cause that shoulder pain. All right. It's not limited to just one thing. So the big thing is, like I said, if we can reproduce it, it's a good thing, because we hopefully can reduce it, and then thus we can affect multiple things for you. All right. So number 4, the single biggest mistake shoulder pain sufferers make. What do you think it is?
Not using it.
What's that?
Not using it. Ignore it.
Yep, same, exactly. Ignore it, not using it. Just put it away, avoid it, that sort of thing, exactly. Perfect. What do you think the next, there's 3 things that people do. So the number 1 thing is, we said that they ignore it. What's the second thing that most people do? After they start ignoring it, if it happens to still be there, but they're trying to ignore it and avoid it, what do you think they're doing next?
Strong pain meds.
They are alternate. They're masking it with medications, injections, whatever the case may be, balms, different things, exactly. All right. What's the third thing you could do if you're starting to have pain? And this is something we advocate for as therapists. Address it. Yep. Take ownership of it. Exactly. So number 5, so here comes the talk of the other part. There's the gravy of the meat and potatoes right here. So the most common causes of shoulder pain. So you can have a problem in the joint, that ball and socket, that shoulder joint. And that can be arthritis, typically. All right, the wear and tear. So if that joint is not allowing that ball and socket to move like it's supposed to, so you've hurt the shoulder somehow, some way, and now you've avoided using it, things have tightened up in there, and now all of a sudden the muscle's weak, and I can't lift it, and things are just kind of clamping down in there, and now I can't move that arm. That ball is going to start rubbing in that socket. There's supposed to be space, typically in there. But what will happen is those muscles will get tight and spastic and everything kind of clamps down, and all of a sudden now, even though it's not that much, but if the rotator cuff, you've got that ball and socket there, now all of a sudden things are rubbing. Rubbing's not good. Friction is not good. Whether it be knees, back, ankles, shoulders, neck, wherever. Rubbing is bad in the body, okay? And things are going to wear down, friction. So that's where the smooth surfaces start to become rock roads and gravel roads, and that arthritis starts to form. So that's not a good thing. So there can be a tear in the muscle, okay, or that tendon. So that rubbing then can lead to that surfaces being a little abnormal and wear and tear, and that rubbing then can wear down the tendon of the muscle and cause it's already weakened, and now all of a sudden that rubbing friction kind of starts to tear it, okay, and that may just take that last little picking the gallon milk up or the kiddo up or whoever. Oh, there you go, and next thing you have a little bit of a tear. So like we talked about the impingement, that's the other part of it. So that impingement happens of where you've got the tendons of the rotator cuff or the bicep tendon getting pinched in there. So though that pinching can cause pain. It's happening here, and it might hurt a little bit there, but all of a sudden now, once again, you've got pain going down the arm because of something else going on. Or it may be pain right there. It may be point specific. We don't know.
How does the doctor know?
How does the doctor know? X-rays will be the first line because that will show how much arthritis is there, how much spacing is there, and if there's some calcification, abnormal calcification in and around the area of that ball and socket, even of your collarbone, where the collarbone comes in here, you'll see if what's going on there. So that's a good, it won't show any of the tendons, it won't show any muscles, but it just shows that. Or even the bursa, which can get impinged upon too. There is something we didn't really even talk about, but it can be there. There is a fat pad. So underneath this, on top of your rotator cuff, there is a fat pad, a bursa. You've heard of those before, right? Okay. There is a thin fat pad that goes over the top, and it can get jammed and irritated. And if it gets irritated enough sometimes, or sometimes blunt trauma, if you happen to fall down on it, and all of a sudden you see this, holy cow, I've got this like softball or baseball sitting in there because it's ballooned out. You can have a large amount of swelling. So you can have some bursitis can actually happen. You don't hear about it so much, but it definitely happens in the shoulder joint as well. But then you take a look at that, get an x-ray done first to see what's going on. Is there no fracture? How much arthritis is going on? What's the spacing look like? And then based on how you present to the doctor or how you present here, then there may be a need for an MRI. Not to say it's absolutely necessary, because hopefully we do enough testing to say, okay, maybe we can then get things narrowed down and figure out, okay, this is what we're going to work on. Because there might be multiple things, and maybe you need an MRI, maybe not. But if we work on these things and all of a sudden you're starting to feel better, really no need for an MRI because we're actually moving in the right direction. Another cause of it is actually just be poor strength or stabilization. So you just might be weak. Maybe it's just been weak for many, many years, and you've been compensating and just doing things wrong for many, many years. And that's all it is. It could be just a strength issue, in which happens quite frequently for our clients. They think it's a rotator cuff tear. They go in and have an MRI. Everything's clean. There's really not much arthritis. All right. They actually have pretty good motion and stuff like that. Full mobility, it's not really limited. Maybe actively they can't go past here, but I can take them full distance. Oh, what's going on? So it might be just a strength issue. Those muscles aren't firing when they're supposed to fire, so things fire abnormally, and that can cause things to bind up and become that impingement syndrome. So the impingement sometimes can just be from weakness, not actual tear or other things. And then the last one, which is one thing that kind of incorporates into all of these together, is poor posture. great American society. Teenagers are terrible now, but we're all bad because we sit and do everything computer-wise. Here we are. We're out doing this, we're driving, we're picking everything up. So everything's forward. And if you can envision this shoulder joint supposed to be here, and all of a sudden now I'm forward. So this is an exaggeration. I am forward. That ball is now significantly forward in that socket, and I'm trying to lift up. All I'm going to do is jam, 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 jam. I'm here trying, okay. You get yourself in a better position, and all of a sudden, hey, I feel it, but wow, I can go a lot farther because I'm tight. My pec muscles are tight. Maybe my spine might be tight because I've been here for many years. I've been out like this, whatever it may be. So we may have to look at the spine as well to say, is there something else leading towards this? But it could be just a total postural, what we call mechanical issue. But there might be, and most times often there is something else. There's muscle weakness into it. There may be an impingement of some sort. And if it's been going on enough time, there may be a tear. There may be some capsule tightness on top of it. So most of the time it's what we call multifactorial, where there's lots of components contributing to it. And there you go. And then I didn't even talk about the neck stuff. We have to clear the neck, but you could be having some neck impingement. The nerve could be getting impinged, and you can have shoulder pain. The nerve can get impinged right here on the collarbone, and that can cause shoulder pain too. And so we have to look at that as well. So lots of different things that we want to look at. It's very complex in there, and that's why try not to take it lightly, and we don't like to try to lump it in all in one thing. And that's why the community know, like, oh, I have rotator cuff. Well, you might not have a rotator cuff problem. You've got pain in your shoulder, but it could be coming from somewhere else. So just to kind of lump it all together isn't always good, because you think then if somebody tells you have rotator cuff because you have these types of symptoms, and then you go to YouTube and I look up rotator cuff stuff and I try stuff and it doesn't work and I hurt the next day, well, it might not be that at all. And that's what we're going to lead to here. So what does successful, non-invasive natural treatment look like? Like I said, we do a lot of hands-on manual therapies work, moving the joint around to loosen it up, postural training, getting segments to move like they're supposed to, get muscles firing like they're supposed to, postural retraining, everything like that. We do a lot of stretching and strengthening. We try to get muscles firing like that have not been. Small muscles will shut down, big muscles will fire. Like the big brother syndrome, big brother will go into spasm and protect and go. Small muscles shut down, and we need to get those muscles firing. So that's important to get that muscle memory going again. We do a treatment called ASTEM, augmentative soft tissue mobilization. It's basically using some plastic instruments. If this has been going on for some time, there might be some scar tissue that's built up. We need to break down that scar tissue. It's a natural way to break down scar tissue and heal itself and start the healing cascade again. We do a treatment called TMR, total motion release, which is kind of almost a 180 of normal physical therapy, but it's a nice tool in the tool belt that thinks about the body being wound up. If you're really, really tight because you've been spastic and everything else, we're tight in one area. If you're so tight in one area, I can't ask you to go any farther because I'm so tight that I need to now unwind you to allow you to go. So it's a different mental philosophy of normal therapy, but it seems to work for a lot of people in certain times. So we use that sometimes. It doesn't work for everybody, but it does. It's a nice tool in the tool belt. And it says, as it says, if the neck involved, sometimes if there's truly neck involvement, we'll do some manual traction or some mechanical traction, distraction, try to open up those segments in the spine to take pressure off those nerve roots, and all of a sudden, yeah, I don't feel that pressure, I don't have that pain, and now all of a sudden we do that mechanical traction. Hey, I don't have that pain in my shoulder anymore. And it was all because of the neck, it wasn't because of the shoulder at all. Okay, so sometimes we'll do that. But the most important part of our successful treatment is that we have to try to really help you figure out what the root cause of the problem is, getting down into the nuts and bolts of it. All right, what questions do you guys have? Yes?
If it turns out it's bursitis, how is that treated?
So a lot of times with bursitis, typically it's a impingement that's caused the bursitis unless it's a fall. So if that bursa is inflamed, a lot of times they'll put a cortisone injection into that area to calm it down, or they'll give you some oral meds. And I'm not saying that's good or bad, but that initial portion of it that's a course that the doctors will recommend. And has it been successful in the past? Yes. Is it absolutely necessary? No, it's not absolutely necessary. Especially if you're not wanting to use meds and not wanting to get injections, you don't have to do that. But that's a typical course that doctors will take, especially if they really truly think that it's bursitis. And it can calm it down. You have an intense medication in that area, right away, calms things down and allows you to do then the therapy maybe that you need to do. Because if it's a fall, you could be strong, good posture, everything's good. It just happens to be an unfortunate incident where you fell, and all of a sudden now, boom, the bursa explodes, and it's irritable, and it just needs time to calm down. Well, you could do that naturally, or you could do it enhanced, and that's your choice. If it's something that's occurred over time, then therapy is definitely advocated on our part, because what's causing that impingement, that's causing that bursa to get irritated? Is it because things are tight, things are weak? What do we need to work on? And we really treat it no differently than we would treat it with others. I mean, we have to determine what's the cause of it, because we have to limit. But the course of action is basically a lot of times is, okay, we need to strengthen what needs to be strengthened. We need to stretch what needs to be stretched. We need to open up the joints that need to be opened up at the time. We need to get certain muscles firing. We need to work on the posture. And a lot of times retraining and cueing people to say, okay, this is what you do. Because naturally, like I said, if they start to reach out and all of a sudden they're doing this, they think they're doing fine. I'm doing great. You get them in front of a mirror and you show them like, oh, I didn't know I did that. So you start to retrain certain muscles to get back. And so different people need different types of cueing and retraining. So we'll work towards that. So, whether it be a shoulder bursitis or whether it be a rotator cuff problem, an impingement problem, or just a joint capsule tightness, we basically take it to the same thing. We find out, step back, get as much information. What do we need to work on? What are we truly dealing with? Because it could be multiple things. And then we address each one that we possibly can. So I hope that answers your question. Yes. Okay. You're welcome. Anything else?
Do these, like if you give us exercises to do we do these for the rest of our life?
You may have to, and you may want to, because they seem to be good. Typically, you normally, with therapy or whatever the case may be, is we will get clients to a certain point and graduate them. And then all of a sudden we tell them, okay, it may take you another month, 2 months, or 3 months, whatever it may be, of you being diligent with your daily home program. And then once you get to the point like, wow, I'm feeling strong, everything's good, I'm feeling really comfortable, and that may be 3 months out, and then you may go to and cut back to more of a maintenance program at that point. And you're doing everything you want to be doing, but you may not have to do it every single day, but you may say, I like these 2 or 3 things, I want to do those every day, but I'm doing everything else maybe just 2 or 3 times a week. And you see how that goes. I'm feeling pretty good, just doing it 2 or 3 days a week. I'm in a maintenance program, I'm happy, I'm great. You may find out that maybe I wasn't as good as I thought I was at 3 months. You start doing that 2 days a week or 3 days a week, and all of a sudden after a month or 2 months, things start creeping back up. Ooh, maybe I wasn't 100% like I thought I was. And you start going back to doing it daily. So it may be something you do for the rest of your life because you want to. It may be something you need to. We can't ever have a crystal ball to say you're going to do it for 2 months or 6 months or whatever afterwards. But we just try to guide them as much as we can. So the come to point is, as Bobby had kind of alluded to earlier, there are different treatment programs for shoulder joints and shoulder pain. Doing the right one to address the cause of your pain results in permanent relief, feeling better, and moving better. Doing the wrong one can frequently make the symptoms worse. Programs may have some overlap because multiple factors, like I talked about, are affecting that shoulder joint. So, want to show you a couple exercises now, and you're going to get this. So, when you hand or do your survey at the end, and you hand it in to Christina and Christian, they'll give you these pictures of exercises. So, we're going to show you a couple of doorway stretches, kind of a thing, or you can do them in the corner of a wall, where a clean corner where it's open and stuff like that. If you happen to have one of those in your house, I do not, so I have to do a doorway. And then one postural muscle, it's kind of a muscle recruitment, semi-strengthening depending on how you do it, to get things firing again. So the first one is put your clipboards down, and we're going to pretend that you're all going to be in a doorway, but go ahead and stand on up again for me, please. So you're going to get into a doorway or step yourself into a corner, and we're going to put our hands down by our side with our palms facing forward. And you're going to put each hand on either side of the doorway or the door jamb. All right? And that may be enough, and you're just going to stand up in good posture. And that in itself may be enough for you, but you're standing directly in the doorway, the door frame. That may be enough to feel a stretch throughout the front part of your arms, your bicep, and the front part of your shoulder. If that's not enough, then you pick a leg, left or right, does not matter, and you take a small step forward, and you keep your arms back, okay, as if it's in the doorway. And now you're going to intensify that stretch from elbow up across to elbow, all right? Deep breathing, good posture. We're not looking at the floor, especially our carpet. It's not that impressive. You know what shoes you're wearing for the day or not shoes if you're doing it barefoot at home, all right? So we're not looking up, we're not looking down, good posture, deep breathing, and no pain. The biggest thing with stretching is there's no pain. With all things with therapy related, the no pain, no gain, you can come relax. The no pain, no gain theory does not work. If you create pain, you're creating inflammation. If you create inflammation, you will take steps backwards. The no pain, no gain theory does not work, okay? So you'll be doing that. 20-second holds roughly, and it's all on the sheet of paper, roughly 20 seconds. Shake it out, do it again. Shake it out, do it again, 3 times typically. And then you're going to move to a position of here. And it may be this is comfortable to you, maybe not, Bobby, right? Maybe it's more here. You know, you figure it out, but we want to try to get to a position of mid. So whether arms are out here, so the hands again on either side of the doorway, maybe your hands are here, whatever's comfortable to you. You know, ultimately we want to get here, but I'm not worried about that right now. But if you get somewhere in the mid-range here, same thing, you're just going to stand in that doorway, good posture, in this position, all right? And the reason we do you in a doorway or a wall is because if you did it here by yourself, you're using those muscles, right? If you put yourself up against the wall or door, your arms can relax. You don't have to hold them up as much, okay? And same thing, again, if this is not enough being in the doorway like this, you may take a small step forward to open that up even more. You're going to feel it a lot more across here versus the first one with the arms down, you're going to feel it more across here. So we're stretching everything out in the open. 3 times for 20 seconds roughly. And you can do that periodically throughout the day. Once a day would be mandatory. Twice a day would be good. 3 times a day would probably be optimal. So morning, afternoon, and evening. Especially evening before you go to bed. If you're having difficulty sleeping, this might be something that gives you some relief sleeping-wise. Okay? All right. Inflammation, swelling. Yeah. So if that has been irritated enough where you've jammed it, compressed it, overused it, then the inflammatory response happens and basically more blood flow goes to the area, capillaries open up, and the inflammatory response happens, and you've got a lot of neurotransmitters and chemicals going out there, and it basically wants to be swollen at that point. And so that extra blood flow, and if you really damage a lot, then you damage the tissues, and the fluid from inside those tissues will leak out, and that causes more swelling. No, you're fine, Allie. That's a great question. All right, so those are the 2 stretches you're going to do. And then the last one is an exercise where we're going to basically work the muscles because we've got the bad posture, okay? We need to squeeze our shoulder blades together, okay? Nice and easy. Same thing, you can think about good posture, head up, level, okay? You can do this sitting in a chair, you can with your arms in an armrest, in the car at a stoplight, you can do it standing, you can do it any position. You don't have to be up in here, arms down by your side is totally fine. You just want to squeeze the shoulder blades. Hold it for a little bit. Now the big thing is, if you do it in front of a mirror is what I advocate for people to start with, because some people do this. Yeah, I'm squeezing up. And what are they doing? They're actually elevating their shoulders because they don't know how to shut these muscles off when they recruit their shoulder blade muscles. So they'll be doing it. Oh yeah, I'm doing it. No, you want to just pull it straight back. Okay, nice and easy. Don't cause cramping. That's not good either. But just go. And you may feel like, oh, something's stopping me. It may be because you might be locked in here, and that gives us an indication. You can come back like after 2 days of doing the exercise, like, "Ooh, Joe, you have me done. I just can't. I can feel like I hit a brick wall." Well, maybe you are, because there's a segment or 2 in the spine that is not allowing you to do that. So we have to work on that. We open that up, and all of a sudden, oh, now I can do it. That's great. So just working on those multiple repetitions. You can hold it if you want to hold it, but just working on that posture throughout the day, just thinking about being in better posture, especially if it hurts to reach. All right, so maybe if I'm at the counter and stuff like that, and all of a sudden I need to get in that cabinet to get that coffee cup, oh, that really hurts. Well, of course, what do? You use your opposite arm, right? Well, maybe I stand up, I gently squeeze my shoulder blades together. Hey, I feel it, but not nearly as bad. It's still there, but man, that helps a lot. It may be a mechanical issue. Oh, wow, there we go. So those are the exercises I'm going to have you start to work on. See if that kind of helps or not. They're basic, but they're really integral. We start everybody baseline. That's two of the things they go home with every time when they come in for any shoulder stuff that we have. So go have a seat. Thank you so much. Except for you, Bobby. I'm going to have you come back up. I'm going to finish up here in a few minutes. So you're left. So I'm going to have you. Let me get this for you here real quick. We're going to go ahead and lie on your back with the head up there. I apologize for not getting that out of sooner. Sorry about that.
You weren't expecting the shortness.
We call it gravity deprived.
Oh, okay.
All right. I'm going to do a little quick work here on your collarbone, okay, to see how that's moving a little bit. I'm going to do a little work on your shoulder joint, which we didn't do the other time as well, and see if that helps improve anything for you, okay? You have to let me know, though, if it hurts. Don't be a martyr. You have to let me know, okay? All right, good. You will feel pressure, I guarantee you, but I just don't want it to be painful for you.
It hurts a little on the shoulder or on the clavicle.
Okay, yeah. Most people don't have their collarbone pushed, so you're going to have some pressure, some soreness, yeah. But nothing shooting down into your arm or anything like that. Okay.
I kind of want to go like that, though.
That's why I put you. I got things blocked. I've been hit enough in my life. It's okay. Is that one all right?
It hurts a little.
More than the other one, or is it about the same?
About the same.
Okay.
Maybe a little more.
All right. So now I'm going to have you stay on your back and slide towards me. I'm going to move the pillow with you. Keep coming, so we're going to bring your shoulder all the way just off the edge. Your hip's going to stay there, but just move your shoulder and your head over. Perfect, right there. I'm going to slide that down. I get to do all the work, okay?
Okay.
All right. So as best you can, you relax that. All right.
I feel nothing.
Good. So what I'm doing now is I'm just working on opening up that shoulder joint, that ball and socket, and kind of distracting it out of the ball, out of the socket itself.
I can actually feel it. Doesn't hurt though.
Good. How long has your shoulder been hurting you?
Only a month,
Okay, so it's relatively new.
and I've managed to make it much worse.
Well, you're active, right?
Not really.
No.
Actually trying to help it, but making it worse.
Okay. All right, so now I'm going to do a little pressure down. Are you okay there?
Mm-hmm.
All right, good.
Feel a little pingy.
Okay. All right. So now, last I'm going to do here on this side, or this way, is I'm going to kind of push the ball down a little bit. Good. You okay with that?
Mm-hmm.
Is that the easiest out of all three of them?
Mm-hmm.
Okay. Good. All right. You get to hold that there. We are going to try something else here. I'm going to put this towel roll underneath you here. It's going to feel uncomfortable right along your shoulder blade. All right. All right. You okay in that position?
Mm-hmm.
Okay. Let that elbow rest. All right. I'm going to put pressure down through your elbow and going down to stretch out the back part of your shoulder here.
Yeah, I get a lot of pain behind my shoulder blade.
Okay. So once again, you have to let me know. I'm going to sneak my hand there. Are you okay with that?
Mm-hmm.
Okay. I'm going to do a little distraction there. And a little pressure down. Good, bad, ugly, what are we talking?
I feel pressure, but I don't really feel pain.
Good. I'm okay
Kinda
with that.
feels good.
I'll take that even. You still doing okay?
Mhm.
All right, we're going to incorporate a little rotation now with it.
That hurts a little bit.
Okay, same spot, just hurts? Or different spot?
Different spot.
Okay. Is that angle a little better or worse?
Worse.
Okay. But that's better if I don't rotate it so much. Okay. I'm not here to irritate you, so we're not going to. But that lets us know that there's a little deficit right there. We need to be able to rotate that. Okay. All right. Really quickly, let that relax. Do a little distraction here.
A little behind my shoulder blade.
Okay. All right. I'm going to pull the bolster out from underneath you here. You can sit up on the edge of the bed there. I'm going to grab the stool there for you to slide on out. All right. Now, oh, well, 1 second here. So I want you to try
Feels better.
raising that arm up a little bit now and see if it's any better or not.
For the front?
Whatever typically would bother you.
Yeah, that feels better.
Okay. That one still hurts a little bit. Okay. But out front's better?
Yeah.
Okay, good. Thank you so much. All right, so that's just a little bit more of it's slash assessment for us. Some joint assessment is what I did there on our ball and socket. I had done the other things beforehand. Now I completed that more of assessment, but then I took it into a treatment as well, where we assess the ball and socket not moving like it's supposed to, and then we do some treatment to try to stretch things out. That there's a capsule, a saran wrap membrane capsule around that ball and socket that needs to get stretched out a little bit. So muscles have to get stretched out. This capsule has to get stretched out to create that better spacing in there. And then we're able to do that. And that's where a lot of where Bobby's is at right now is she's got some tightness in there. It could be just muscle tightness, but it also could be that muscle it's her non-dominant arm. Who knows if it's been maybe creeping up for some time where there's been a restriction and all of a sudden now it's just kind of showing itself. Don't really know. Haven't gone through a formal, thorough evaluation, but you know, those are the things that we would be looking at. Any questions? All right.
Is it more typical to have an issue with your dominant side?
Not necessarily. I mean, most people will say yes, and I will say maybe tendency to yes because you use that and you overuse it. But a lot of times we see the non-dominant come in because it's been weaker for the years. So maybe for the last 10 or 15 years, it's not been used as much. It's been weaker, and then all of a sudden you do something with it, heavier, more resistive, whatever, and all of a sudden, then that's the final straw. So it might be that. So maybe tendency, yes, but not all the time. So most people I say I'd rather have it be my non-dominant arm because then I at least can do stuff. So, but I won't say that all the time. All right. So to recap, shoulder pain can be caused by osteoarthritis or OA in the joint. RTC is rotator cuff, can be a rotator cuff tear. One of the 4 muscles can tear or tendons. It can come from impingement problems. It can come from poor strength or stabilization, and then also poor posture. So there's lots of things that can cause shoulder pain. And we didn't even include the neck in there too, so the neck can also be a part of it. Like I said before, if we can reproduce the pain, usually it's a good sign that we can reduce it, so we look for that. The big thing is, and if you've been dealing with it for a while, shoulder pain affects everybody's life differently, like we talked about as far as activities-wise, but it can have a major impact with what you do on a day-to-day basis. Decreased sleep and concentration, avoiding and missing family activities, work activities, community activities, whatever you're a part of. Lead to depression, increased medication use a lot of times, and that's the whole opioid epidemic that we're having now and trying to get away from. And even missed work days, which is not good either. So just letting you know that pain affects everybody a little bit differently, but it can have a major impact, especially if you're dealing with it for a longer period of time. All right. Anybody have any other questions or anything? Yep.
It's been 8 days since I fell. and I'm getting a lot of grief from family for not having gone to the doctor. So I haven't had the x-rays or the MRI or anything. Is it something that you could physically just manipulate like you did with Bonnie to see if it's something I need to go to a doctor for, or if physical therapy would help me? I'm afraid to go, that my dad's had a couple of rotator cuff surgeries
Sure.
that were unsuccessful.
Yeah.
I assumed that's probably what I have, and I don't want to go the same route he did. So I don't really know what I have, though.
Yeah, we can, and therapy is always a good first entry point if and it's a safe entry point, because we're not going to recommend that you have surgery, because that's not our scope of practice. But yes, I mean, therapy is a great entry point to go get evaluated. And we do have direct access now, so we can evaluate clients without having a doctor's prescription now, as of August of last year. So, but if we feel that, yeah, therapy is recommended, but we better have you get a picture of this because of what we evaluate, or maybe an MRI is necessary, then we're going to send you to a doctor at that point in time to say, yeah, you need to follow up with your an orthopedic doctor, or maybe it's even just your primary, whoever it may be, to get x-rays or to get an MRI, because there's some stuff going on that we're just not so sure about. So we had to make those recommendations. So we were, that is totally up to you. Yeah, for sure. All right. Without any other questions and stuff like that, definitely want to make sure that you fill a survey out so you get the pictures of the x-rays, or the x-rays, of the exercises. She mentioned x-rays, so I have it in my brain. So the exercises of the door stretches and the shoulder blade retractions. So fill out that survey for that. And if you didn't want to be a part of the video, just let Christian and Christina know and stuff like that. Take your name so we can take care of that logistics if necessary. But what I want to offer everybody for coming out on their Saturday morning, thank you so much. And unfortunately, it didn't get quite as cold, and maybe it didn't snow and stuff like that. I'm so happy for that. That if you want to take advantage of what we have to offer, or if you want to move your health forward, we're more than happy to offer you a free screen for coming out to kind of find out where you are at, what your shoulder pain is at, and we can help you decipher what's going on, and then what's maybe the best next steps for you. If therapy is appropriate or not appropriate, what we would recommend, and give you that opportunity. If you wanted to just go all in and say, I want to do therapy, and want to schedule an initial evaluation, we can do that too, but definitely want to give you the opportunity to talk with myself, Julie, or Shay, and say, okay, what's the next best steps for me? We do a quick screen, ask some questions, answer some questions from you, and kind of find out if therapy is good or not, appropriate or not, and what would be the next best steps. So we can do that as well. So Christina and Christian can help you with that, or I can help you with that too. I'll be sticking around for answer some questions, and I'm going to be here for a little while. So yeah, thank you so much for coming today. And if you have other questions down the line, you can email me, you can call, you can stop in. Don't hesitate to ask. We are here for the community. So thank you so much.